I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness.
Today, we have a special treat for you, a debate between Dr. Roger McIntyre and Dr. Andrew Cutler on the topic of when do side effects warrant switching medication. This debate was recorded on April 27, 2019 at NEI's Synapse Conference in Asheville, North Carolina. Let's listen in as Dr. McIntyre begins the discussion.
We're going to have this discussion, and it's illustrated by this case. A 28-year-old female patient has a diagnosis of bipolar depression and has been taking lurasidone. We should say been prescribed lurasidone for 2 months. There's a difference.
There is.
At a follow-up appointment, she complains of sedation. At what point do side effects warrant switching? Okay, so McIntyre, medications should be switched immediately. Let me start off with a couple of comments. Whenever I see a patient, for example, who has depression or bipolar disorder, I ask the patient, has anyone in your family had a mood disorder? Yes, no. If yes, I ask, have they been prescribed treatment? And then the next question is, how do they do on the treatment? Now, I'm not doing that so much because I have a scientific basis around genetics, because mom or the sister responded to Prozac, therefore Prozac would be the treatment. What I'm really trying to get at is the family's attitude toward the medication. And we know that familial attitudes and so on and biases will affect that particular person's thought processes. And where the thought processes become particularly profound is when mom or the sister, the brother, whoever in the family, has had all kinds of side effects. And then I talked to the patient, I said, any of your friends been on these medications? Oh yeah, my friend John was on this. He thought that stuff was garbage and all kinds of side effects. Because I'm trying to ascertain the attitude, the bias.
Prejudice.
And we know from the compliance or the adherence or the concordance literature, whatever language you prefer, that these biases are powerful and they're often shaped around tolerability. Certainly in the case of research and clinical trials and in experience clinically, when patients take medications and they have side effects, which are often expectancy type side effects because they have this mounted expectation it might happen, they in fact are very inclined to stop the medication and not tell you. And this is something which is a major contributor to insufficient outcomes with treatments. So my impression clinically has been that once a patient has a side effect ingrained into their hippocampus, ingrained into their brain, it's impossible for me to get that out in terms of a modifiable factor. So when it comes to tolerability, depends if it's a small t or a capital T tolerability concern, I often quickly engage in switch because the family, the friends, and the patient literature says they're unlikely to stay the course. If you keep prescribing it, they ain't going to take it.
So low energy Roger doesn't know what he's talking about. Don't be swayed by his incredibly cool hockey haircut, all right? All right, let's talk serious here.
Is Andy going to be blinding us with science here?
Well, I may not be as verbally adept as my Canadian colleagues, so I actually had to prepare some slides here to remind me. And I'm going to start off with a quote from actually a friend of ours, Terry Ketter. Fellow Canadian, bipolar researcher. I was sitting in an advisory board with Terry one time. He said something that stopped us all. You know how Terry sort of sits there, he's kind of quiet, and then he'll just say something that gets the whole room, right? Yeah. So he goes, you know, it occurs to me that one of the biggest risks of our medications is lack of efficacy. And we all just went, oh my God, he's right, you know? So the point is that if you find an efficacious medication, yeah, if there's some tolerability and side effects, there are ways of dealing with these side effects. So the risk of untreated or inadequately treated mood disorders, as we know, are huge. Then there's the issue of time to onset of some degree of efficacy versus maximum efficacy. We know from our clinical trials, if you watch the graphs, the improvement always continues over weeks. So you want to convince the patient, hey, you're starting to get some better. This isn't as good as you're going to get. So when you're thinking about the risk-benefit and the tolerability, what are the risks of switching? Well, we don't talk about this. The efficacy issue, of course, withdrawal symptoms, drug-drug interactions, financial cost. And then there's a very important point here, which is tolerability versus safety. Tolerability is something usually that's more annoying to the patient, as Raj was talking about. Usually not life-threatening, often self-limiting, things like nausea. And then don't forget there are nocebo effects. A nocebo effect is a patient who gets side effects even if they're on placebo. I do clinical trials all the time. I'm always amazed that placebo causes headache. You know, every clinical trial, 30%, 30% headache. Safety is more important. Safety to me is life-threatening. So clearly I would argue, for all of these reasons, that as long as something is not a safety issue, and I divide safety into acute and chronic. Acute would be, anaphylaxis, Stevens-Johnson's. Chronic or metabolic and things you've heard us talking about. So that's where I'm at, Raj.
Okay, very, very robust, compelling. Yeah. So Andy's memory is obviously very short term.
Oh, it is, extremely.
Because if I recall, and I stand corrected, I think he said something during the earlier debate about the duration of untreated psychosis.
DIP.
And Andy made the case that the longer the duration of untreated or insufficiently treated psychosis, the less favorable it is for the patient at the clinical level, probably at the biologic level.
Yeah.
So I want to pick up on that theme because we know in depression and bipolar and in schizophrenia, the longer the illness is allowed to be overtly active, maybe even covertly active, the more likely we see progressive changes in the brain. And what I would be concerned about is a scenario wherein I'm prescribing the medication and it's not being picked up at the drugstore, and the person's illness, again, bipolar, major depression, schizophrenia, continues to be at the very least overtly active, if not covertly active, and this is only stacking the cards against my patient and stacking the cards against the efficacy of the next treatment. Because one of the realities of the sequential treatment of bipolar and major depression is that each sequential therapy has a diminished rate of return.
So true.
And that might be in part because with each sequential therapy, something happened, time went by, and that time may have changed what we call the biotype. That is the biology of the type of condition you're trying to treat. So I think, in fact, that a pragmatic view would be if the patient's having tolerability concerns jeopardizing their concordance, adherence, compliance, then I think it's time to jump in, find a treatment collaboratively, and get them on the right course to nip this thing in the bud.
Well, Roger's obviously underestimating his ability to connect with patients and his ability to create an honest dialogue with patients. He's assuming patients are just going to stop their meds and not tell them, and that's it. So he's just saying that tolerability is the key to efficacy, that if you have any little side effect, that's it. Everybody's going to stop and nothing's going to work and brains are going to melt. I, on the other hand, like to establish a very close and honest relationship with my patients. And I warn them about the potential of side effects. People don't like surprises. That's what I find. So I warn them and I tell them, okay, you might have a little nausea. It'll get better in a couple of days, or we can lower the dose. We can use some of Raj's great strategies. And I tell them, look, before you stop the medicine, let's talk about it. I'm not here to be your father, your policeman. I'm not going to judge you. Let's talk about it. So you can manage through a lot of these side effects. But, maybe Roger has a different view.
Okay. So maybe, in fact, just some summary remarks. Keep us on time. Mm-hmm. And that is that what I've been quite struck by is when I sit with a patient in my office, that when I start listing the side effects, I haven't even written the prescription yet. The patient starts getting the side effects in my office, and I haven't even written the prescription yet.
Nocebo effect.
I say this medication might cause dry mouth, and the patient's saying, Dr. McIntyre, do you have water? I'm really thirsty. I haven't given the prescription yet. And so there's actually this significant expectancy. And over the years, frankly, I've kind of been uncertain. Do I tell them, of course, we don't tell them all the side effects, because that wouldn't make much sense. You do want to talk to the more common side effects.
That's what I do.
Am I sowing the seed, which will then create the expectancy?
Exactly.
Or do I kind of play this sort of don't ask, don't tell game?
Right.
But then what happens is they go on Dr. Google, they get the drop-down menu,
That's right.
and they call you up, and they hone in on a side effect that affects 0.000.1% of patients.
That's right.
So I think it's absolutely essential to speak to these side effects at the front door, candidly, reliably, and and so on. And I do think, in fact, that if we can manage those side effects better over the first 2 weeks, we're home free. That's been my experience.
Okay, home free.
We're home free. In other words, what I have noticed is what you've all noticed. Patients come to the clinic and they've had 3, 4, 5, 6 different treatments, and they say, I've got treatment-resistant illness. And then you find out they don't really have treatment-resistant illness. They've stopped the treatment after a couple of weeks, insufficient dose. So what I have found over the years is, for me, have that candid conversation about tolerability, find out where your patient's threshold, there's temperamental differences, etc., in their propensity to reporting side effects, work with the patient. In some cases, I'm going to say stop and go elsewhere. In other cases, I'll try to help the patient through that first 2 or 3 weeks and just keep pushing it. But taken together, there's no question that once the patient forms the opinion that this side effect ain't good for me, it's probably game over, time to move on.
Well, that may be, but I believe in our powers of persuasion, at least in an educational way. And I believe that we can educate patients when thinking about these side effects, the importance, again, of balancing out the risk of inadequately treated illness, which we often don't think of as a side effect or a risk. But I'm reminded of that terrific Focuser video. How great was the Focuser video on choose your own side effect, right? Love that. That was So what I do often is, I actually, in addition to, I come down on the side of warning patients about the most common side effects. I don't go with all of them, but the most common one they're likely to experience, and kind of make it not such a big deal. But I also do something funny. In addition to what Roger said, I actually really do that all the time. Is anyone else in your family taking this medicine? And you'll get, my cousin's a pharmacist, and they said, don't take Risperdal. Your head will explode or something like that. Well, I'm not going to get them to take Risperdal. But what I do is, I also ask them, are there certain side effects that would bother you more? And you'll be very surprised when you hear this, because we all know that weight gain, for instance, is bad. But there are some people who are exquisitely sensitive to nausea. Whatever you do, don't make me nauseous. Well, then I choose a medicine to some degree based on side effects. So that becomes another data point in helping me select a medication. And so the video of choosing your side effect actually kind of does enter into my thinking, or at least choosing the one you don't want, and that helps me select the medicine. So I've been very successful, I would say, at working with patients and getting them to treat through some of the side effects that are tolerability issues. But of course, Roger and I would both agree, if there's a safety concern, then you definitely would want to switch. Okay. So with that, I close my winning argument and turn it back over to Roger.
Okay, very good, very good. Okay, let's go back to the case. The 28-year-old female has a diagnosis of depression as part of bipolar illness, is prescribed lurasidone for 2 months, at follow-up is having sedation. 1, should that medication be switched immediately, or should be switched immediately only if side effects are dangerous?
The point here is, of course, we've kind of separated this into some kind of black-white issue that's really gray, and I think we both made compelling arguments on both sides of the issue.
So one of the interesting points about this is people have often asked me, at this juncture, if the patient is having side effects, would I do gene testing?
Oh.
At that point?
Oh, get that all the time.
And I get that all the time.
Yeah.
And I've often scratched my head.
Is there any evidence or science that could guide us in what we say?
Well, this is an important point, and I think it's a point of confusion, and it's probably worth mentioning because it dovetails into the case.
Yes.
And what we can say is that in some cases, some of the time, the use of so-called combinatorial genetic testing may shed some light in terms of explanation and maybe further guidance.
I would agree.
That's something I think the field agrees on.
Yeah.
And I use it, for example, in a patient who's of Han Chinese background. If I'm prescribing carbamazepine, I'm concerned for, say, Stevens-Johnson syndrome. The question really is it ready for prime time in all patients all the time? And the answer is no.
And particularly, not only pharmacokinetics, which you can tell you your fast or slow metabolism, but pharmacodynamics, to actually choose the medicine and match that up, I think there's evidence that that's not ready.
That's correct. So it's promising, but not prime time, folks.
This podcast was brought to you by NEI's Master Psychopharmacology program. This is an NEI member benefit that is designed to help you develop proficiency in the practice of psychopharmacology. Start your program today. For additional information, see the link in the podcast description.